For individuals undergoing hemodialysis, the vascular access is quite literally their lifeline, the critical gateway that makes life-sustaining treatment possible. This access is a specially prepared site on the body, usually in the arm, where blood can be easily and safely removed and returned during the dialysis process. Without a well-functioning access, effective dialysis is simply not achievable. There are two primary types of permanent vascular access that are surgically created for this purpose: the Arteriovenous Fistula, or AVF, and the Arteriovenous Graft, or AVG. Understanding the fundamental nature of each, how they are created, and how they function, is the first and most important step for both patients and the technicians who care for them. Their durability and health directly impact the quality of treatment and the patient's overall well-being. An arteriovenous fistula, often referred to as the gold standard for dialysis access, is a direct, surgical connection made between an artery and a vein. Typically created in the patient's non-dominant arm, this procedure allows the high-pressure, high-flow blood from the artery to enter the vein. Over a period of several weeks to months, this increased blood flow causes the vein to enlarge and its walls to thicken, a process known as maturation. This makes the vein strong and wide enough to withstand the repeated needle insertions required for dialysis. The AVF is created entirely from the patient's own blood vessels, which is a significant advantage, as it avoids the introduction of any foreign material into the body. On the other hand, an arteriovenous graft serves the same essential purpose, but is constructed differently. An AVG is created when a patient's own veins are not suitable for creating a fistula, perhaps because they are too small or have been damaged. In this case, a surgeon uses a soft, synthetic, biocompatible tube to connect an artery to a vein under the skin. This tube acts as an artificial vein that can be cannulated for dialysis. Because it involves synthetic material, a graft can often be used sooner than a fistula, sometimes within 2 to 3 weeks after the surgical procedure, as it does not need a long maturation period. It provides a robust alternative when an AVF is not a viable option. The choice between an AVF and an AVG is a significant medical decision made by the nephrologist and vascular surgeon in close consultation with the patient. This decision is based on a thorough evaluation of the patient's vascular anatomy, often mapped out using ultrasound. Factors like the size and health of the patient's arteries and veins, their overall medical condition, age, and previous access history are all taken into consideration. While the AVF is generally preferred for its longevity and lower complication rates, the AVG remains an indispensable option for many patients, ensuring they too can receive reliable and effective hemodialysis treatment. A well-informed understanding of both options is key to successful long-term care. When evaluating the best type of vascular access, the arteriovenous fistula, or AVF, presents several distinct advantages. Its primary benefit is its superior longevity and durability. A well-developed fistula can last for many years, sometimes even decades, providing a reliable access site for dialysis. Because it is created using the patient's own tissues, there is a significantly lower risk of infection compared to other access types that involve foreign materials. Similarly, fistulas are less prone to clotting or thrombosis. This leads to fewer interventions, hospitalizations, and complications over the long term, contributing to a better quality of life for the patient. The blood flow in a mature fistula is also typically excellent, which allows for more efficient and effective dialysis treatments. Despite these considerable benefits, the AVF is not without its drawbacks. The most significant disadvantage is the maturation time. An AVF requires a substantial period, typically ranging from 6 weeks to over 4 months, to develop properly before it can be used for dialysis. This delay means that a patient might need a temporary central venous catheter while waiting for the fistula to mature, which carries its own risks of infection and other complications. Furthermore, not all patients are suitable candidates for an AVF. Some individuals may have veins that are too small or weak to create a successful fistula, resulting in a failure to mature, which can be a frustrating setback in their treatment journey. The Arteriovenous Graft, or AVG, offers a compelling alternative, especially for patients who cannot have an AVF. The primary advantage of a graft is its much shorter break-in period. An AVG can typically be used for dialysis within 2 to 4 weeks of placement, minimizing the need for a temporary catheter. This makes it a practical option for patients who need to start dialysis treatment more urgently. The surgical procedure can also be more straightforward in patients with challenging vascular anatomy, as the synthetic tube bypasses the need for a suitable native vein. For many, the graft is a dependable and necessary bridge to receiving consistent and timely dialysis when a fistula is not feasible. However, the use of synthetic material in an AVG brings its own set of disadvantages. Grafts are associated with a higher risk of both infection and clotting compared to fistulas. The synthetic tube is a foreign body, making it a potential site for bacterial colonization. Clots can form more easily within the graft, often requiring procedures like angioplasty or thrombectomy to restore blood flow. Consequently, grafts generally have a shorter lifespan than fistulas, often lasting only 2 to 3 years before they may need to be replaced. This can lead to more frequent surgical interventions and a greater long-term burden on the patient's healthcare journey. Meticulous daily care is absolutely essential for maintaining the health and longevity of any vascular access, be it an AVF or an AVG. The first and simplest rule of daily care is cleanliness. The skin over and around the access site must be kept clean to prevent infections, which can be a serious complication. Patients should be instructed to wash their access arm with soap and warm water every single day, and especially before each dialysis session. It is important to gently pat the area dry with a clean towel rather than rubbing it vigorously. This simple hygienic practice forms the foundation of access care and significantly reduces the risk of bacteria entering the bloodstream through the needle sites or any small breaks in the skin. Beyond cleaning, daily self-monitoring is a critical habit that every dialysis patient must adopt. This involves using the senses of touch, sight, and hearing to check the access. The patient should be taught to gently feel for the thrill, which is the soft, continuous vibration or buzzing sensation caused by the high-volume blood flow through the access. They should also listen for the bruit, a whooshing sound that can be heard with a stethoscope, or sometimes just by placing an ear near the site. Checking for the thrill and bruit every day, perhaps in the morning and evening, is a quick way to confirm that the access is open and functioning properly. Any change or absence of these sensations requires immediate medical attention. Visual inspection of the access arm is equally important. The patient should look for any signs of trouble, such as redness, swelling, warmth, or drainage like pus, as these are classic indicators of a potential infection. They should also watch for any new sores, blisters, or peeling skin over the access site. Any significant changes in the appearance of the arm, such as new bulging areas or skin that looks shiny and stretched, should also be noted. Keeping a close eye on the physical state of the access arm allows for early detection of problems, which often leads to simpler and more effective treatment before the issue becomes severe enough to threaten the access itself. Finally, protecting the access arm from any form of trauma or excessive pressure is a crucial part of daily care. This means being mindful of the arm during all daily activities. Patients must learn to avoid sleeping on their access arm, as prolonged pressure can compress the vessels and lead to clotting. Similarly, they should not carry heavy bags, purses, or other objects over that arm. Even something as simple as wearing a watch, bracelet, or tight-sleeved clothing on the access arm should be strictly avoided. This constant state of protection helps preserve the delicate structure of the fistula or graft, ensuring it remains healthy and patent for as long as possible. Proper preparation before each dialysis session is vital for ensuring a safe and effective treatment while minimizing the risk of complications. The first step, as mentioned, is hygiene. The patient must thoroughly wash their access arm with antibacterial soap and water just before arriving at the dialysis center or before the technician begins the cannulation process. This removes transient bacteria from the skin surface and is the first line of defense against access-related bloodstream infections. Technicians must also follow strict aseptic techniques, including hand hygiene and wearing gloves, and should clean the needle insertion sites with an approved antiseptic solution, such as chlorhexidine or alcohol, using a circular motion and allowing it to air dry completely before needle insertion. A pre-dialysis physical assessment of the access site is a non-negotiable step for the dialysis technician. This involves more than just a quick glance. The technician must carefully feel for the strength and consistency of the thrill along the entire length of the fistula or graft. They should listen for the bruit, noting its pitch and character, as a high-pitched sound can indicate stenosis or narrowing. The skin over the access should be inspected for any signs of infection, aneurysms, those weak bulging spots, or skin breakdown. It is also crucial to ask the patient if they have noticed any changes, pain, or problems since their last treatment. This thorough check helps identify potential issues before needles are inserted. Protecting the access arm from injury and undue pressure is a 24/7 responsibility that extends far beyond the dialysis clinic. We have a simple but critical list of do's and don'ts that must be reinforced with the patient at every opportunity. Do: check your access for the thrill and bruit every day. Do: keep the skin over your access clean at all times. Do: use your access arm for gentle exercises, like squeezing a rubber ball, to help it mature and stay strong. Do: rotate needle sites for each dialysis treatment to prevent weakening of the vessel walls and aneurysm formation. This rope ladder technique is crucial for the long-term health of the access. Conversely, the list of don'ts is equally important for preventing damage. Don't let anyone take your blood pressure, draw blood, or place an IV line in your access arm. The arm should be clearly labeled with a medical alert bracelet. Don't wear tight clothing, jewelry, or watches on your access arm. Don't carry heavy items or sleep on your access arm. Don't ignore signs of infection or clotting, such as redness, pain, swelling, or a loss of the thrill. By diligently following these guidelines, patients and their care teams can work together to protect this precious lifeline, ensuring it functions well for years to come.